Atrial tachycardia. Classification of atrial tachycardia. Definitive satisfactory classification of atrial tachycardia is difficult because ECG classification is obsolete. Electrophysiological classification is not also fully satisfactory, due to the significant overlap in the electrophysiological characteristics of tachycardias. Electrophysiological classification of atrial tachycardia. 1. Focal atrial tachycardia, in which the site of origin is small and cannot be mapped with a standard 4 mm tip catheter beyond a single point, or a few adjacent points, and the impulse spreads in the atria in a centrifugal pattern. This type is classified according to its electrophysiological mechanisms into automatic, microreentrant, and triggered form, the least common. 2. Macroreentrant atrial tachycardia, in which the site of origin is large, generally several centimeters in diameter. This type is maintained by a reentrant impulse, with exit spread to the adjacent atrial tissue. This is differentiated from atrial flutter based on an arbitrary rate cutoff value less than 240 beats per minute, while 240 beats per minute or greater is called atrial flutter. Atrial flutter is considered, by many, a type of macroreentrant atrial tachycardia, but with a faster tachycardia rate. In the focal type, a focus is firing repetitive impulses, which spread centrifugally, while in the macroreentry type a single reentrant impulse with exit spread maintains the tachycardia. It is to be noted that in both focal and macroreentrant types, reentry may be involved, either micro or macro reentry. Site of origin of focal atrial tachycardia. Like atrial flutter, most focal atrial tachycardias arise from the right atrium, along the crista terminalis, crystal tachycardias. Other sites include around superior and inferior vena cava, coronary sinus, and pulmonary veins ostia. Mitral and tricuspid annuli. Right and left atrial appendages. Around the His bundle. Atrial septum. Etiology of focal atrial tachycardia. Structural heart disease is common, especially coronary artery disease, unlike in AVNRT and AVRT. Chronic obstructive pulmonary disease. Electrolyte imbalance. Drugs, for example digitalis. Epidemiology of focal atrial tachycardia. Non-sustained focal atrial tachycardia is frequently found on Holter recordings. Sustained focal atrial tachycardia is relatively infrequent. Atrial tachycardias increase with increasing age, probably due to changes in cellular coupling and autonomic influences. Clinical presentation. Paroxysmal atrial tachycardia may present as infrequent short paroxysms, or a frequently repetitive tachycardia interrupted by short periods of normal sinus rhythm. Even the frequent form may be tolerated well for years, causing symptoms only in cases of fast heart rate. Incessant atrial tachycardia may cause tachycardia-induced cardiomyopathy and heart failure. Evaluation. History, physical examination, 12-lead ECG, and echocardiography are used. The diagnosis of atrial tachycardia, however, can be established with certainty only by an electrophysiological study. ECG features. Focal atrial tachycardia cycle length is usually 250 ms or greater, that is, heart rate is 240 per minute or slower. Intra-atrial reentrant tachycardia and automatic atrial tachycardia are similar in the following ECG criteria. Distinct P-wave is seen before each QRS. P-wave morphology may indicate the site of origin. Usually there is a clear isoelectric baseline between P-waves, but it may not be evident in high rates, or with intra-atrial conduction defects where the P-waves are broad. Atrioventricular block may occur without affecting the arrhythmia itself. Differentiation. 1. Inducibility. Reentrant tachycardia can be induced and terminated in electrophysiological studies, unlike automatic tachycardia. 2. First P-wave. Reentrant tachycardia usually starts with a premature atrial contraction, as a trigger for reentry, which has a different P-wave from that of the tachycardia itself, while automatic tachycardia starts with an identical P-wave to that during tachycardia. ECG differentiation between atrial flutter and focal atrial tachycardia depends on 1. An arbitrary rate cutoff of 240 beats per minute, atrial tachycardia being slower. 2. The presence of an isoelectric baseline between atrial deflections in atrial tachycardia, but not in flutter. However, neither rate nor lack of isoelectric baseline is specific for any tachycardia mechanism. P waves and QRS complexes in atrial tachycardia. QRS morphology during atrial tachycardia is narrow, unless there is aberration or coexisting bundle branch block. PQRS relationship in atrial tachycardia is usually 1:1, but Wenckebach or 2:1 avenue block without tachycardia termination can occur at rapid rates, in the presence of AV node disease, or drugs that slow the AV node conduction. In the presence of AV block during an SVT, without its termination, atrial tachycardia is favored. AVNRT is less likely. AVRT is excluded. Atrial tachycardia usually has a long RP interval, but the RP interval can also be short. Sites of origin of AT and P wave morphology. Right atrial origin, the P wave in V1 is either negative or biphasic, positive followed by negative, since the impulse travels away from V1. Left atrial origin, the P wave in V1 is either positive or biphasic, negative followed by positive, since the impulse travels towards V1. Negative P waves in most chest leads suggest an anterior atrial origin. Negative P waves in lead 3 and AVF suggest a low, inferior, atrial origin. P waves arising near the atrial septum are generally narrower than those arising in the right or left atrial free walls. Termination of AT. With spontaneous termination, atrial tachycardia terminates with QRS complex, following conduction of the last P wave of atrial tachycardia. Or with V wave following conduction of the last A wave of atrial tachycardia. This schematic shows a high right atrial, HRA, channel and a right ventricular apex, RVA, channel of an EPS during atrial tachycardia. The last A wave of atrial tachycardia conducts to the ventricles, creating V wave, arrow, so that atrial tachycardia terminates with V wave seen in RVA channel. Sinus rhythm, then starts. Can atrial tachycardia terminate with AV block? Reproducible termination with P wave not followed by QRS or A waves not followed by V wave, practically excludes atrial tachycardia. It will occur in atrial tachycardia only, if atrial tachycardia terminates, at the same moment the AV node decides to block, which should be extremely unlikely. Maneuvers in focal atrial tachycardia. Vagal maneuvers can terminate micro-reentrant and triggered atrial tachycardia, but automatic atrial tachycardia will show transient slowing followed by recurrence to the basic rate. Micro-reentrant atrial tachycardia can be terminated by adenosine. Automatic atrial tachycardia can be terminated by beta blockers. Triggered atrial tachycardia can be terminated by adenosine, verapamil, beta blockers, and class 1 antiarrhythmic drugs. Electrophysiological studies in atrial tachycardia. The pattern of biatrial activation may differentiate between atrial tachycardia and atrial flutter. Biatrial activation in focal atrial tachycardia usually occupies only a small fraction, less than 50%, of the cycle length, but occupies most, around 90%, of the tachycardia cycle length during atrial flutter. As seen in this figure, biatrial activation in focal atrial tachycardia usually occupies only a small fraction, less than 50%, of the cycle length. Biatrial activation occupies most, around 90%, of the tachycardia cycle length during atrial flutter. Effects of bundle branch block. Unlike orthodromic AVRT, bundle branch block during atrial tachycardia does not affect the tachycardia cycle length, because the ventricles are not part of the atrial tachycardia circuit. Tachycardia entrainment with ventricular pacing. As discussed earlier, AV response after termination of ventricular pacing during tachycardia practically excludes atrial tachycardia, while AAV response is diagnostic of atrial tachycardia. Multifocal atrial tachycardia, MAT, or chaotic atrial rhythm. This rhythm is due to the irregular discharge of multiple atrial foci. It can be confused with atrial fibrillation, but in MAT there are well-formed P waves. ECG diagnosis requires the rule of 3. The identification of P waves having 3 or more different morphologies that occur at different PR intervals, together with different RR intervals. The rhythm is usually chaotic, non-ordered, and the rate is usually less than 140 beats per minute. MAT is commonly associated with underlying lung disease, metabolic abnormalities, electrolyte disturbances, and in rare instances toxic causes such as digitalis intoxication. Thank you.